Welcome and thank you for joining us in parallel session one. I am going to give it just 1 or 2 or maybe 10 seconds for everyone to join in. Thank you for taking time out of your World Cup watching marathon. Or maybe I'm talking to myself where that is concerned, being an avid soccer fan. But welcome again, and thank you for joining us in parallel session one. The title of this panel is The Pandemic Pandora's Box, Long COVID, Episodic Disability and Employment. My name is Tammy Yates Rajadure, and I'm a proud member of the National Disability and Work in Canada Conference Steering Committee. And I say a proud member because, believe me, it's a Herculean effort to get this show on the road. Before I hand over to Melissa Egan in 1 minute, Melissa is the panel moderator for this amazing session. I'd like to ground us by acknowledging Turtle Island, now referred to as Canada, and the lands on which we may all be situated and from which each of us is joining the conference today. Currently, I am on the traditional unceded territory of the Algonquin and Anishinaabe people, now referred to as Ottawa. We pay our respects to the elders of this nation, past, present, and future. As part of the interactive nature of this conference, there will be a live Q&A session after all of these presentations. Following the panel presentations and this Q&A, there will also be a networking session from 2:05 to 2:25 p.m. So please do feel free to stay on and join us. And that'll be specifically designed as an opportunity for delegates to join the discussion, share your thoughts, ideas, and suggestions. If the conversation has started as part of the Q&A, you are free to continue that conversation in the networking room. So to ask questions during the live question and answer session for the panel, as well as the networking session, you have the option of typing your question in the Q&A box or in the chat. The Q&A feature and the chat is going to be monitored by the amazing Zoom team I have here with me and will be moderated in the session. You may also raise your hand in Zoom and you will be unmuted to be able to ask your question if that is your preference. It's really my pleasure now to pass you over to Melissa. Over to you.
Hello, everyone. Welcome to the session. Thank you so much for being here with us today. We have created this session based on a deliberative dialogue that Realize hosted a couple of weeks ago, well, quite a number of weeks ago, honestly, that we called the National Deliberative Dialogue on Long COVID as an Episodic Disability and Employment. And this was a gathering of many, many people where what we wanted to do was really dig in to what long COVID looks like now, what we're grappling with, the way that we're talking about it, and how employment is being impacted. We also invited people from many different stakeholder groups to speak with us and to engage in dialogue. This ended up being a very rich and informative day. A few of the speakers who were at this event are going to be part of this panel today. By way of introduction, as Tammy said, my name is Melissa Egan, and I am the National Lead of Episodic Disabilities at Realize. Realize is a national organization, and we try and foster positive change for people who are living with HIV and other episodic disabilities. We've been around for nearly 25 years, which is incredibly exciting for us. And we've always been very innovative in the way that we approach conversations and work by bridging traditionally separate worlds of disability, HIV, and rehabilitation. We do our work by engaging in many different aspects of how change is undertaken. We do research, we do education, community building, and we work towards policy and practice change. We are very proud to be the Secretariat of the National Episodic Disability Forum. We are the host of the annual National Summit on Episodic Disabilities and Employment. We are active in policy work with government. We develop accredited online trainings, and we offer workshops on episodic disabilities at work to organizations across Canada. With that said, I would like to now pass things over to the incredible panelists who are going to be there, who are going to be here rather. First, I'm going to ask Kira McDuff to present. We will then hear from Sherry Ingalls. Jessica DeMars will come next, and then we will close things out with a presentation from Tanya Houghton. We will also, if we have time, invite you to chat with us, to ask questions, and to really engage in the conversation that we're having. So that's everything from me for now. Welcome, Kira.
Thanks so much, Melissa. So hi, everybody. Thank you so much for the opportunity to present as part of this panel today. My name is Kira. I'm a physiotherapist with clinical experience in critical care, including experience working with patients with acute COVID-19. And I'm also the research coordinator for the Long COVID and Episodic Disability Study. And it's in this capacity, through my involvement in the study, I've been lucky to learn about long COVID from a really strong research team, which includes many people with lived experiences with long COVID, and from being involved in conducting some of the interviews and data analysis as well. I'd like to begin by acknowledging the land on which the University of Toronto operates, as that's where I'm joining you from today. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, this meeting place is still home to many Indigenous people from across Turtle Island. I'm very thankful and grateful to have the opportunity to work on this land. So the aims of my presentation today are first to define long COVID, second to discuss the concept of episodic disability and the episodic disability framework as it relates to long COVID, and third to share evidence and updates from the long COVID and episodic disability study. To get started, it's important to define long COVID. So I'd like to first say that the term long COVID was coined by people who were experiencing lingering and lasting symptoms after acute COVID at a time when there was no public or medical recognition that there might be long-term consequences of COVID infection. Social media provided a forum for this group, and together they collectively defined and described long COVID and brought awareness and attention to the issue. So although you might hear other terms suggested, such as post-COVID condition, I'm going to continue to use the term long COVID out of respect and recognition to those who brought this to our attention in the first place. The World Health Organization defines long COVID with the following criteria. It occurs in individuals with either a probable or confirmed case of COVID infection. The onset is usually 3 months from the initial COVID infection, and the symptoms last for at least 2 months. There is a multidimensional nature to long COVID, which symptoms often include fatigue, shortness of breath, and cognitive dysfunction, and which often impact daily functioning. The definition also states that symptoms may fluctuate or relapse over time, which indicates that there is an episodic nature to long COVID. There are a number of hypotheses about what underlying biological mechanisms may cause long COVID, such as viral persistence, immune dysregulation, and endothelial cell dysfunction. Some suspect that there will be different phenotypes identified of long COVID with unique underlying causes or biological mechanisms. Ultimately, further research is needed to identify what these mechanisms are that are driving long COVID, and this will have important implications to inform both the diagnosis and the treatment of long COVID. In a 2021 systematic review, it was found that 80% of people infected with COVID will have at least one symptom that will last beyond 2 weeks. The 5 most common symptoms of long COVID were fatigue, headache, attention disorder, hair loss, and dyspnea, or shortness of breath. However, long COVID can manifest with a wide array of symptoms affecting various systems in the body. And often people with long COVID will experience many different symptoms that might wax or wane over time. And this complex presentation can make it very difficult to evaluate and understand the symptoms of long COVID. It's also important to note here that these persistent symptoms can develop regardless of the initial severity at time of COVID infection. The Canadian COVID Antibody and Health Survey was administered earlier this year. The survey asked about new or continuing symptoms 3 months or more after a confirmed or suspected case of COVID-19. In this sample, 14.8% of adults with confirmed or suspected COVID-19 experienced longer-term symptoms. Almost half of these respondents indicated that their symptoms were lasting at least a year or longer. Over 20% indicated that their symptoms sometimes or always impacted their daily activities, and 75% of those who were employed stated that they missed some work or school due to the symptoms that they were experiencing. The most common symptoms were generally echoing what was defined in the World Health Organization definition. And really the take-home message here is that with the significant prevalence of long COVID and the associated impairments and disability that people with long COVID are experiencing, there is a role and a need for rehabilitation. Understanding the disability that is experienced by people living with long COVID has important implications for practice, research, and policy. I'd like to introduce the concept of episodic disability and the episodic disability framework, which has been rigorously developed and validated in the context of HIV. Episodic disability refers to any physical, cognitive, mental, or emotional health challenges, difficulty carrying out day-to-day activities, challenges to social inclusion, or uncertainty or worrying about the future that an individual may experience, and that may fluctuate over a daily basis, within a day, or over a longer period of time. Briefly, I'd like to share some evidence and updates from the long COVID and episodic disability study. The aim of phase 1 of this study is to conceptualize the disability experiences among people living with long COVID in Canada, the United Kingdom, the United States, and Ireland, and to establish the episodic disability framework within the context of long COVID. Semi-structured interviews were conducted with 40 adults living with long COVID from the 4 countries. I'd like to highlight that 50% of our participants reported being unable to work at the time of the interviews. Participants described their experiences of disability as episodic, characterized by a diverse range of health challenges, and which resulted in both short and long-term fluctuations in health. Some of these fluctuations were unpredictable and made it difficult for participants to plan the future. Some of the terminology that our participants used to describe the episodic nature of their experience included describing it as similar to a roller coaster or a yo-yo. And people also would say that their symptoms were waxing or waning and that they felt like they were going through peaks and valleys. Participants described episodic disability as a continuum with fluctuations that might occur over different time frames. Some participants identified as having a permanent disability in that they experienced a constant state of disability and loss of function relative to their baseline health. However, they might have experienced an episodic nature in some of their symptoms within the context of an overall persistent state of disability. Dimensions of disability included physical, cognitive, and mental and emotional health challenges resulting in difficulties with daily activities and social inclusion. Health challenges might occur in clusters with differing severity, presence, and duration of episodes. And finally, many participants referred to the concept of invisible disability. So certain symptoms such as fatigue, headache, and cognitive dysfunction are not visible to others. And it was at times difficult for participants to articulate and have their health challenges recognized as disability. Overall, what we're finding is that the episodic disability framework does appear to apply in the context of long COVID, and there's ongoing work to explore what potentially unique features might be emerging in the context of long COVID. I'd like to thank the entire research team involved in this study. As you can see, it's a big team, and there's a lot of ongoing work. So I'd really like to thank everyone on this list for their contributions to the research. A few take-home messages here. I'll just highlight a couple of things. So disability experienced by people living with long COVID is multidimensional, and it can be episodic in nature. People living with long COVID often experience challenges to their everyday function, which may limit their ability to participate in work. And there's an urgent need to understand what's driving long COVID and to develop access to safe rehabilitation and treatment. Thank you so much for listening to this, and I'm happy to take questions at the Q&A.
Thank you so much, Kira. That gave us a really nice foundation to really have an understanding of what we're going to be discussing and learning throughout the session. Next, I would like to invite Sherry Ingalls to speak. Sherry has been working alongside Realize for about a year now. Sherry is part of our group of storytellers who really help to create resonance and connection for people who are learning about episodic disability and long COVID. Over to you, Sherry.
Thanks, Melissa. Kira, thank you so much for that overview. I could definitely see myself in everything that you were saying. My name is Sherry Ingalls. I am a former registered nurse, and I have long COVID. I have the privilege to be speaking to you today from Calgary, the traditional territories of the peoples of the Treaty 7 region in southern Alberta, which includes the Blackfoot First Nations tribes of the Siksika, the Piikani, the Kainai, the Stoney Nakoda First Nations tribes of Chiniki, Bearspaw, and Wesley, and the Tsuut'ina First Nation. The city of Calgary is also homeland to the historic Northwest Métis and to Métis Nation of Alberta Region 3. I did not expect to get COVID or long COVID. I did my best to avoid it, and I followed the rules. Let me take you on my journey through the highs, the lows, and the status quos of living and working with long COVID. It's Christmas 2020, and the best present ever was getting out of isolation to celebrate with my family. I tested positive for COVID on December 14th. So now I'm out of my room and I finally get to hug my husband and 3 kids. My dog won't stop licking me. She missed me too. I can't stop crying. Too bad everything smells like rotten garbage, cigarette smoke, or diesel fuel, and tastes even worse. At the end of January 2021, I'm back at work, but COVID seems to have really deconditioned me. I'm used to having to get my cardio fitness back after a cold, but this is excessive. Bending over to put my compression stockings on, I stand for 12-hour shifts as a maternity nurse. It spikes my heart rate to 120 beats per minute. And the constant fatigue, I don't have energy anymore to work out before going to sleep after my shift, whether day or night. I just curl up and I conk out. March 2021, I spoke with my manager and my physician about my ongoing fatigue, shortness of breath on exertion, and high heart rate. I have modified duties and hours at work. My doctor referred me to the long COVID clinic running out of one of our hospitals in Calgary since it's been 3 months, and I'm not back to normal. But my referral was rejected because my symptoms aren't primarily pulmonary, and I never had pneumonia as part of my symptoms. At least my doctor is no longer saying it's all primarily anxiety anymore. Yay, no more gaslighting. There's an old Michael McIntyre Christmas special on parenting that I used to show all my maternity patients. He talks about how things that you don't know will become things, will become downright impossible once you have kids. Well, long COVID is like that. Things that you don't know will become things, become downright impossible. June 2021, I'm not sleeping well. Waking unrefreshed, fatigued all the time. I have headaches every day. Sometimes they're so bad. They wake me up from sleep. I finish work and I ache like I'm coming down with a flu. I get chills. I have uncontrollable sweating. I take multiple COVID tests whenever these symptoms appear and they're all negative. I learned this is called post-exertional malaise, and it's common in long COVID. Apparently, I need to pace my activity so I'm not exceeding my energy envelope. Physical, mental, and emotional exertion can trigger post-exertional malaise. I work with high-risk moms and babies. That's pretty much the definition of my job. I also found out that my workers' compensation claim got denied this month. So now I can't stop working to rest and take care of myself. Oh well, just keep on keeping on, I guess. I have further reduced my hours and duties. This is now August 2021. My body is falling apart, and now I'm also having difficulty with word finding. On August 25th, I'm sitting for most of my shift, taking care of a newborn infant while my colleagues are trying to save her mom's life. At home, I can't even sit up for 10 minutes without pain. I go on short-term disability, pardon me, and I appeal the workers' compensation decision. On my birthday, in December 2021, I got a call from workers' compensation. My appeal went through and my claim has been accepted. Best birthday present ever. August 2022, or October 2022, reflecting on this last year, I still have a lot of physical challenges. I use an electric scooter to help save energy, and I just got a scooter lift installed in my vehicle. I can't stand for greater than 10 minutes without getting dizzy and fatigued. So I have helpers come for household chores and meal preparation. I've gone from spending 90% of my waking hours in bed to about 50% of waking hours in bed. I feel guilty for not working during this healthcare worker shortage, but I can't even perform CPR. It's a basic requirement for the job. I keep trying to think of different ways that I could possibly be of any kind of use whatsoever. My brain is still active. I still have all the knowledge of a registered nurse. But physically, I can't do any of it. 90 minutes in a doctor's appointment gives me post-exertional malaise for 4 days. So where do we go from here? Well, keep on keeping on. Recovery, that's what I have to focus on. And hopefully, now that policy has changed from back in 2020, and now that people have more knowledge of long COVID and people are getting the support that they need, my story won't be as common. Thank you.
Thank you so much, Sherry. I have heard this story probably 4 or 5 times now, and every single time there's that little pinch in my heart, and I'm hopeful that hearing stories like this is the path to creating more change, to fighting some of the stigma that people who are living with long COVID are experiencing, and to really impacting the way we move forward as people who are at work and the way that we treat each other in a workplace context. Thank you again, Sherry, for your bravery and for your tenacity. This is a very challenging experience that you're going through, and I am deeply grateful for the way that you share your story with us. I would like to now ask Jessica DeMars to turn on her camera and talk to us a little bit about the work and the resources that she has been creating. Over to you, Jessica.
Thank you for inviting me to speak today. I'm a physiotherapist who's working in both British Columbia and Alberta with a special interest in respiratory conditions and now working with people with long COVID. I'd like to acknowledge that the land on which I live, work, and play in Nelson, BC is the unceded traditional territory of the Ktunaxa, Syilx, and Sinixt people. Today, I'm going to speak about a document that myself, Kelly O'Brien, community experts, produced on recommendations on return to work for people living with long COVID. And this was a collaboration between Realize Long COVID Physio and the Rehabilitation Science Research Network for COVID, Temerity Faculty of Medicine, University of Toronto. I've been working with people with long COVID since around July of 2020. By the fall, I started getting a lot of referrals for individuals who are being managed through workers' compensation or were on short or long-term disability. And it was obvious based on my conversations with case managers and on the experience of my patients that the industry was struggling with how to manage long COVID claims. There was a lack of understanding regarding long COVID, mainly because the science and medicine didn't really understand it either. Existing rehab models and recovery expectations were being used, and a lot of it was based on a deconditioning theory and pulmonary rehabilitation models. However, it was clear that people with long COVID did not fit into those traditional program models. Even for myself, I found it was difficult to capture the functional impairments and episodic disability that comes with long COVID, which then made it difficult to communicate this with case managers, employers, and even other health professionals. Individuals were often having to advocate for themselves, trying to describe their symptoms and their impact on function, often having to explain their story to multiple different people, whether case managers or healthcare professionals. This kind of self-advocacy was increasing their own burden of care. So as a co-director of advocacy for long COVID physio, I felt it was important to create a Canadian-made document to help educate and guide those working in the industry and to actually reduce the burden of people living with long COVID as they navigate these pathways. So it was really important that this document provided a voice for people living with long COVID, and we engaged with members of the community to help us highlight what the most important points that should be considered by managers, those in the industry, when you are considering disability management and potential return to work plan. So just going to kind of take you a walk through. This is our draft version of the document. We're really excited that by the end of the week, we should be releasing the finalized version, which will be in French and English and in a much easier to read format than our draft version right now. And so I know this is a really busy slide, and I apologize for that, but I just want to highlight what we found kind of the most important messages to get across. First of all is highlighting what is long COVID and the symptoms associated with it, as Kira has explained for us already at the start of this presentation, but really important to have that solid understanding of what we think we know about long COVID right now, and maybe potential causes for it, which, you know, this is still being heavily researched, but there is enough information out there that gives us a foundation that something is wrong physiologically. Something is wrong with the body's physiology that is creating these symptoms. However, many of our tests right now are not sophisticated enough to detect it within the general population. So again, in the research format, in labs, we're seeing things that are changing, but again, not super accessible if you just walk into your, general practitioner's office and get referred to a lab. So highlighting some of the symptoms, the fact that symptoms are episodic, and the impact on function of day-to-day life. So each of these, whenever throughout the document, whenever you see something underlined, there will be a hyperlink that you can click on that takes you to a little bit more of an enriched experience about that. So it'll describe a little bit more in depth. It'll provide references so that you can understand better what might be happening. So we want it to be accessible for people living with long COVID. We want it to be accessible to those in the industry dealing with disability. So we highlight the lower portions here. Again, this is going to be laid out much cleaner after this week. The impact of symptoms on function, so whether it's day-to-day activities, how it might impact a workplace environment. If we have cognitive dysfunction, a sedentary job, sitting at a desk doing computer work, which previously had been considered kind of like an easy way to get people to return to work after an illness or injury, it may not be attainable. We wanted to highlight rehabilitation management because many in the disability world, of course, are referring for rehabilitation, so physiotherapy, occupational therapy. However, again, when we're dealing with post-viral illness, such as long COVID, it's going to be a drastically different approach than what those of us in rehabilitation have normally done. So we wanted to highlight some of the safety considerations when referring someone to rehab, both for rehab professionals to understand, but also for those in the disability management world to understand that it's going to look different. Rehab is going to look different, and your expectations are going to be different. And then we wanted to look at things that we need to consider when we're assessing for return to work and those return to work recommendations. Both of those are tailored around the individual. So not all of our previous physical testing is going to be appropriate, especially when we have people experiencing post-exertional malaise, post-exertional symptom exacerbation. So again, highlighting that we are all going to have to shift our bias and potentially come up with new ways to assess for disability, to create accommodations for return to work when we're considering episodic disability. So again, this will be available on the resource page on Realize's website. The draft version is currently available, but by December 3rd, we should be having the finalized version. Within the document, we have created a large reference list, scientifically evidence-based. We really wanted to highlight that this is, we have evidence behind the statements that we are saying. And in addition, we've provided resources, and the resources are to further enrich your learning, right? So you can understand better each section, or where do I learn more about managing post-viral illness? Where do I learn more about managing long COVID? And again, this will be available on the Realize website under the resources section. I'll stop sharing. I'm happy to answer questions about that at the end as well.
Thank you so much, Jessica. This has been such a labor for everyone, really. It's necessary, and it's taken time because of the careful consultation that has gone into it. This is not something that has been just created by clinicians. This is something that really involved people with lived experience. So that kind of duality is what's baked into the resource. So we are hopeful that this is something that you will be able to use as people with lived experience, but also as practitioners and clinicians. I know that Jessica, her team, and a whole bunch of other folks are working to create another resource. So we're hoping to see that in the new year. These things take time, but this one will be about people who are living with, focused on needs, focused on tips, and that sort of thing. So if this one works for you, there's another one coming. All right. So thanks very much to Jessica for sharing that. Our last panelist is Tanya Houghton. Over to you, Tanya.
All right. So jumping off of what Jessica just said, and I think a lot of this will kind of tie up what is being seen clinically in a compensation system. You know, what we're seeing across the nation does differ slightly, but in discussions with other compensation boards, it doesn't dramatically shift. So today I'm going to talk to you about the very quickly the incoming volumes and trends, as well as what we've seen in terms of return to work outcomes. The long COVID analysis, so what we're kind of seeing with respect to what is defined as long COVID, how we have responded to that as an organization, and then questions we'll save for the Q&A. So as you can see, the numbers over the past couple of years have been following this. We didn't want to go into too much detail, but they have been following exactly what we see in community, with the majority of cases coming in 2022 due to the nature of Omicron and the other variants since that time. So in total, we've had roughly 19,000 claims registered at WorkSafe BC. And you can see there with respect to the allow rates, they have stayed pretty consistent and high. 2020 does seem a little bit off. And that is because we had a lot of kind of confusion on when people should file or not. And so people were filing when they believed they'd been exposed, but they'd actually never contracted COVID. But you can see there in 2022, so we've had, the better part of 10,000 allowed claims, and we continue to receive about 30 a day. And that's on average. In terms of what we've seen on our allow rate, our overall allow rate, which I didn't go into here just out of respect of time, is about 87%, 88%. And that's when you take into consideration ones where people filed them and it was really an exposure only. But what you'll see here is the breakdown in classification units, which is those areas of sectors. We refer to them as classification units within a compensation system. And not surprisingly, long-term care, public school districts, and acute care are the marked three that have maintained kind of a consistent number into the system. Our return to work rates, and I know we're here to talk about long COVID, but I think it's important to also talk about the successes of COVID. Majority of people do return to work, and they return to work relatively quickly. So this data is as of the end of October. And you can see there, over 14,000 claims were allowed at that point. And of those, 14,275 have concluded. So 97% of people had successfully returned to work, with 91% of them returning within 4 weeks. And that's pretty standard. Today, and I'm going to go into this a little bit more when I get to those slides. Today, we're here to talk more about those approximately 331 claims that we have currently, what we refer to in continued active wage loss. So they're considered to be, they still are temporarily disabled by long COVID and the symptoms that have come out of that. My apologies, I have a dry throat. So you'll see here on Omicron, the average days paid. You're gonna have to bear with me so hold on. I'm grappling with the same cold that's going on with everybody. So you'll see here the average days paid for Omicron is 10 days. And the reason that's important is what we've seen on our long COVID claims, or post-acute COVID, we've been calling them within the system, is that about 50% of them are over a year old. They're from that 2020, 2021 window when we didn't have a vaccine and or the variants were much more severe. And so while we do have claims in pay where people are currently temporarily disabled, they're not, that's not really what we're talking about in this group of claims. So here is those claims that are considered over 90 days. The reason we use 90 days is that is kind of the definition of what we define as long COVID. And so again, exactly the same makeup of classification units, the acute care, long-term care, and public school districts, roughly the same breakdown. You can see there that they are a bit swapped with long-term and public school district. But what that tells us is that it is proportionately about the same number of people going into what we define as long. So like what Jessica and Kira said, symptomology is pretty consistent with what we're seeing. Vestibular and neurological conditions. And so, dizziness, that kind of thing. Aggravations of pre-existing is a big one we're seeing. So people who may have had either unmanaged diabetes or managed diabetes that has now become aggravated is one example. Ongoing pulmonary and cardiovascular issues that, like Jessica said, things might not show up on tests, but objectively, people are saying, look, we're really struggling. And what we're seeing too is when we attempt a GRTW, similar to what has been said before, people are not able to kind of maintain that pacing that maybe they did before. And so really, I think some of the challenges faced from a return to work perspective is for employers as well as compensation systems or insurers to work very proactively with the employer the treatment providers and the individual who is ill, to really kind of lean into that objective and subjective evidence. There is not a lot of objective evidence all the time on some of these situations. And then similarly, not surprisingly, we're seeing a fair number of secondary psychological conditions stemming from long COVID. So for those people who were, in the ICU, they may have been intubated. That's, you're leaning more towards PTSD. But for those people who have had long COVID following maybe not quite a severe case of COVID, what we're seeing is now a lot of anxiety or depression that in addition to dizziness and fatigue and heart palpitations. And so really from a complexity standpoint, and I think Jessica said this, no one case is the same. Similar to other kinds of injuries, illnesses, or diseases that we do deal with, you have to really be cognizant of leaning in to be to approach it on a case by case and the unique merits of each situation. So from a response standpoint, in 2021, because we'd had enough time under our belt by that point, early 2021, we recognized the need for our own post-acute COVID pathway. The community programs had created post-acute COVID clinics. However, as a workers' compensation system, we weren't, while we're able to access them, we would have to wait just like everybody else. And the challenge with that is that it does take up the space for a public system, our public patient. So we mirrored the exact same post-COVID clinic approach within our visiting specialist clinic at WorkSafe BC, working very closely with the primary care physician and our internal medical advisors. And so you can see here the way it flows through at the 4 to 8 week mark of ongoing symptoms. And we refer at that point to the post-COVID clinic. That information then kind of comes back to our team to look at what kinds of further investigations or specialty resources we need. We also have a rehabilitation program. So we've got specialty interdisciplinary services, internal occupational therapy services that are provided, as well as any other additional kind of OR2, so occupational rehabilitation, potentially pain management or other concurrent care programs. And then we work with the primary care physician throughout this, as well as the employer where we're at that time, where we're at that place. But I would say this piece around the MA, our medical advisor internally, and the primary care physician is critical to the success of this program. So barriers to return to work, and I did speak to this a little bit, but I would say the treatment provider skill and the nature of the treatment we've seen is critically important. Not all treatment providers are well versed in this, and I think Jessica is I think probably a bit of a unicorn in both the research understanding and kind of the nimbleness and creativity. Some of our treatment providers just don't know what to do. And so a lot of that is us trying to kind of work with them and educate. We have a very strong medical team with a public health background. And so they're very committed to this. The pacing and energy envelope is a really tough one because similar to some of our other conditions where maybe they're kind of invisible in nature, our employers don't always really understand what that means. And so we've needed to do a lot of education on what that means. Comorbidities, like any time you have an injury or illness, obviously where you have other conditions that are either further aggravated or further creating further barriers to return to work, it's just a reality. And I would say, last but certainly not least, I would say this is the most important barrier to return to work, is what that relationship with the employer was prior to contracting COVID and what the workplace culture was and is. So where we have a very strong relationship with the employer and the worker, and a workplace culture that embraces creativity and nimbleness and a trusting environment, we're having a lot of success in finding modified and gradual return to work opportunities. Where we're not, we're obviously not. And so really, we've done a lot of education with employers on this piece because it's critically important to seeing success so that people can return to feeling like they have a sense of agency in their own life and contributing again in whatever way they can, because sometimes that might only be 3 hours a day. And maybe that is something that needs to be celebrated rather than seeing it as, oh, I can only get here, when actually that would be amazing. And then last but not least is the common threads of success. So having those trusting and supportive conversations. So within a compensation system, that's not just with us. So I mean, our case managers, our occupational therapists, our nurse advisors, wrapping around the worker, but also the employer having those trusting and supportive conversations, the treatment providers, helping somebody see what they're able to do as well is critically important, because it's very easy for what we're seeing, in this population of individuals, is feeling like they're kind of unable to do anything, or that they're constantly set back. Instead, celebrate those little things, because the small milestones can mean a lot. Even if the next day you don't have that milestone, you did achieve it on one day. The collaboration is critically important. And then the last two are really, I would say, interdependent of one another. Creativity, as well as nimbleness and an iterative approach to return to work and or recovery is critical, because you might take 2 steps forward and 1 step back, but it doesn't mean that you've not actually achieved something.
Thanks so much, Tanya. It's always amazing to get this little opportunity to see inside some of the workers' compensation, kind of the way that you work. It's not often something that we get to see. So I am grateful for just how transparent you have been with us today.